Good evening. Minorities in gender and sexual identity, presented by me, Barbara Sweetwine. So the main problems in both of the works, the first work we're going to talk about is called Asexual Identified Adults, Interactions with Healthcare Practitioners. The problem in this reading is that asexuality is being pathologized, which ultimately means that practitioners are perceiving asexuality as a condition that needs to be fixed. Now, according to this article, not all practitioners were recorded as pathologizing asexuality, but the problem being presented is that it is being pathologized. Pathologizing asexuality makes patients feel uncomfortable, which reduces the likelihood that they'll seek medical attention, which in turn leads to lower health outcomes for the asexual community. And the main problem in the second reading, which is called Inhospitable Healthcare Spaces, Why Diversity Training on LGBTQIA Issues Are Not Enough. So the main issue in this article is that heteronormative microaggressions are pervasive in healthcare spaces, which means that patients are also feeling unwanted and invisible due to a subset of these heteronormative microaggressions, which are verbal microaggressions, environmental microaggressions, and system microaggressions. So verbal microaggressions is basically like um, is when you use like the wrong pronoun, and even when being corrected, you still use the wrong pronoun. It's basically just all in your words and your language, your verbal language. And then environmental microaggressions are seen in like the media of the healthcare offices and spaces, such as brochures, posters, little commercials that they would have on the TV screen. So it's basically the environment that is not giving way to inclusion for the LGBTQIA community. And then system microaggressions are exampled through policies in the healthcare spaces, such as intake paperwork, where they ask if you're gay, bisexual, or straight, but they won't ask about queer or transphobia, or excuse me, or transgendered. And just in the system and the functionality of the healthcare, there's a lot of gaps that exclude the recognition of the individuals in this community. Okay, so these subcomponents of the heteronormative microaggressions that I just mentioned, they also reduce the likelihood that LGBTQIA members will seek medical attention, and the reduction of seeking medical attention leads to lower health outcomes, and that is the same problem seen in both readings. To further clarify, I'd say that a feeling of being misunderstood and uncomfortable in spaces where our trust and comfort is most important, which is in the doctor's office. So, patients in both of the articles are in the community and they're just basically excluded, and it's affecting their health outcomes. The differences between the two readings is that the first reading is specifically talking about people who are on the asexual spectrum. There's a spectrum that the journal talks about. You can be demisexual, gray sexual, or asexual. So asexual is basically when you recognize that you have no sexual attraction to anybody, you have no sexual arousal, and it's just not there, and you're not stressed out about it. You're just fine and happy and dandy. And then the demisexual is the person who only finds sexual attraction to someone in which they have a strong emotional connection. And then your gray sexual individual is the person who who kind of sways back and forth between absolutely no sexual arousal, absolutely no sexual attraction, to yes, I'm having some sexual attraction here. So they're in a gray spot. This article briefly mentions intersex individuals who are people who were born with both uh, sexual genitalia. And then the second reading is talking mostly about the lesbian, gay, and bisexual and transgender individuals. They don't talk too much about asexual and intersex people, but so those are like the main differences between the two. Another big difference between the two is the suggestions for solutions. Although the suggestions for the solutions are definitely on the same page, they just have a bit of differences, and we'll go through that right now. So the suggested solutions for the asexual paper is basically a reconstructed diversity training for practitioners. They're basically just saying that the practitioners need to learn how to provide more sensitivity toward the community. When talking to them, they need to be more educated so that they can reflect an environment of acceptance. And so more sensitivity and acceptance will increase those who seek medical attention in the asexual community, and which in turn will allow for an influx of the community who are seeking medical attention, which is going to give us the outcome that we're looking for, which is better overall health outcomes. And so then the second paper addressing the LGBTQIA, they address, the whole gambit of the community, but again, they talk mainly about the LGBT community. But in addressing the microaggressions, what they're saying as a solution is to address the unconscious aspect of the microaggressions, because sometimes we're not always aware of the fact that we even have microaggressions or produce microaggressions. And that was one of the main points about this paper, is that um, the awkwardness and the uncomfort is not always explicit and overt. It's a lot of times unconscious, and the practitioners are just unaware, and they just basically don't even know what to do when they come into a situation with someone who is different from them. So the paper suggested that we can address these unconscious microaggressions with discussions on cultural schemas, the schemas that the practitioners have. Let's talk about, how they naturally feel about the community and how they were raised to feel about it. Also, another suggestion is group work that includes people, the LGBTQIA community, and not only working together in groups, but also taking personal responsibility. And in ways that you can take personal responsibility, you can do some reading, you can watch movies, you can go to community events that incorporate and encompass the community. They also suggest providing scripts for practitioners, such as if you're going to ask someone about their partner, maybe ask them what their gender of their partner is, instead of just assuming that they are heterosexual. And a few more suggestions is that healthcare committees should take into consideration that the community needs more visibility. They should not be ignored. The community is big, alive, and vibrant. And so another suggestion is that they should have more inclusive media, those brochures and posters I talked about. Let's be inclusive on those and not have everything be heterosexual. And the last suggested solution that I'm going to talk about is just basically that more knowledge about the community's experiences and healthcare needs be taught to the practitioners. So, again, the practitioners are not stunned when someone comes in who is different from them. And that is going to wrap up this presentation. References are here. Thank you so much, and have a wonderful night or day.